All right, wonderful. Okay, well, hi everybody. We've made it through a full year of content with our Project Echo. And so the purpose of today's session, I'm going to just do a quick review of why we're here, what our goals were for the year. And then we've had three patients that we presented in a multidisciplinary fashion during the course of this year. And I want to give kind of a rundown of what happened to those patients. So you guys can all get an understanding of what this course of this disease is like. And I hoping for some multidisciplinary conversation from everyone on it. And then we're going to look at what we did. So look at our curriculum that we went through. And I am hoping to get feedback from everyone with regards to what sessions were like the most popular and what maybe we could change, and then brainstorm a little bit about our potential opportunities for next year. So I'm going to go ahead and share my screen. All right. So everybody can see presentation here. Okay.
Yep.
All right. So welcome to our Project Echo wrap up. So why are we here? We're here because amputation is a multidisciplinary problem. So it's a highly preventable complication of diabetes and vascular disease, and something that if it can be picked up early can be prevented. And it's also something that is complicated and involves a lot of different providers, often bringing in podiatry and wound care and other people. So here, I'll just go to the correct slide to talk about that. So as we know, a team approach is essential, and that brings in starting at the primary provider level, and then often, anchored with podiatrists and vascular surgeons in the OR, and then infectious disease, endocrine, wound care, all of these different people. And it really depends on who's participating at your institution, but the teams can be quite robust, and communications are extremely important. But if we do it, we can potentially save up to, have an 86% increase in limb preservation. Problem with these teams is traditionally these exist in tertiary centers. All these specialists are all clumped up at an academic institution, and it's not something that's feasible for rural patients to actually get access to. So the purpose here, so Project Echo, which is this platform that we're using here, is something that originated at University of New Mexico and started because they were trying to help people in more distant rural areas manage issues related to their diabetes. And they found that if they were able to increase the capacity of primary providers to manage the complex diseases, that saved the patients from having to travel really far away and got that care to patients. And so the way that Echo works is that, we have specialists on one end, like a hub, and we have the primary care providers on the other end that are ideally able to bring us questions and patients and learn through these case studies. And so our plan at the beginning of the year was to empower our primary care providers to provide the highest level of care to patients with PAD and diabetes to prevent amputation, doing it in a case-based learning fashion, and to take this concept of a multidisciplinary limb preservation team and actually operationalize it to make it adapted to a rural setting using this telemedicine. So really, again, bringing it to the patient at home. So this will be our 12th session. The number of participants need to be updated. This was when we had 10, but so far, when we had 10 sessions, we had 169 patients that had completed at that point. We've gone through a multiple different topics, and we'll talk about all that. So what I'd like to do is just present, there were a couple of cases that we presented that some of them were to be continued. And so I want to give you the continuation of what happened with these patients. So the first case that I'm going to present to you today is a 73-year-old male that was referred from a podiatry office to the Ruby emergency department with an infected foot wound. His history of significance for diabetes and coronary artery disease, so probably high risk for vascular disease. He basically in November presented to the ER with a foot ulcer from a pair of shoes. had a superficial wound culture that was done. No labs were taken. There was a negative X-ray for osteo, started on augmentin. Culture from the swab came back MSSA. The patient then was seen by podiatry the next week as follow-up and referred to vascular based on a foot exam. And the soonest, we could get them in was about a month out. They were doing betadine dressing and offloading. The patient was then seen by endocrinology about a week later, and they never actually did a foot exam. And then the patient shows up 2 days after that visit with worsening pain, erythema, and the podiatrist sent labs and included an elevated white count, elevated creatinine, a CRP of 73.8. Again, the x-ray was negative for osteo, and they sent them directly to the Ruby ED. And of note, and I mentioned this when I presented the patient the first time, the patient had been seen by CCWV multiple times, not by your two clinics, but by other CCWV providers. And what we saw in the chart was like constantly like, saw endocrine, so they got a foot exam there. So nobody tried to check a foot because they assumed that endocrine was looking. So this was like the original, this is the other side of the foot. So the patient gets into the ED, they get admitted to medicine for IV antibiotics and hydration because of a kidney injury. The next morning we checked an ABI, and so you could see here that the toe pressures were not looking awesome. So this is the right foot. And they look okay up to here, and then they're not really getting any toe pressures here. And then I think we've discussed this throughout the project, but this Wi-Fi scoring, that's something that we do to stage people for how severe their disease is and whether or not they would benefit from revascularization. So for this patient's wound, he does have this extensive, so they have gangrene that's going up and down the midfoot, and you can look at that picture here. And then the ABIs were showing just crappy toe pressures. So if you look here, you can see like it's less than 30. And then there's the infection level. And so here, probably mild. So that's a 331, and you put it into a fancy calculator on your, like there's an app and they put it in there. And then based on that, the patient is noted to have a stage 4 chronic limb-threatening ischemia. And based on the parameters, he's a high amputation risk, and he also has a high potential benefit for revascularization based on the ischemia. And again, because where the wound is, the amount of infection present, and the level of ischemia, these are all the major players when we're looking at these wounds. This patient got hydrated, went to OR for revascularization, and then podiatry saw the patient after the revascularization. Here, there's really just this distal AT and DP disease that we ballooned. Not a ton of other disease present, honestly. We then met with podiatry. So we have this, an impatient MRI that showed this 5th met head osteo, and podiatry discussed the plan to bring him back and debride as an outpatient. ID recommended oral antibiotics with levoprimer, metronidazole, and then follow up with outpatient. And they saw the patient and just changed him, took soft all that, changed him to moxifloxacin, was discharged 3 days later, showed up the next day at his podiatrist, and that's the Michaels down at St. Joe's, and they're not on this call because they're on vacation, but they saw that there was blistering and pain, and so the patient was restarted on IV antibiotics, and they got an x-ray that showed the osteo again. So this is looking, he has more erythema, and there's blistering now present. They took him to the OR that week and did a partial fifth ray amp, and they had a deep wound culture that showed MSSA. Over the patient's course, the CRPs were being followed, and they were followed with ID with the outpatient clinic, and they got DC'd with just on the moxifloxacin. And they were followed then. CRP over time trended from 44.9 to 70.6. His hemoglobin A1C was not terrible, it was at 7. And this is just over time healing. and he healed on March 27th fully. So this is a wound that started in November, December, January, February, March, April, May. So about 5 months, or 4 months. That's pretty good for a diabetic foot wound. But these, again, these are like 6 months to a year that it takes these wounds to heal, and he's still doing okay. Does anyone have any comments on this case? I do think there was a sense, yeah, sorry. I do think there was a sense that we probably, maybe we should have pushed to do the AMP before he left Ruby, because he literally was discharged and bounced back the next day. Does anyone from our podiatry team have comment on that?
I don't know who did the initial evaluation, but I think, for me anyway, personally, sometimes I feel like the patient does better if there's a little bit more demarcation after a revasc, so I know exactly what's going to survive and what isn't. I've certainly had episodes where we've done an amputation and then the surgery site will necrose and further necrose, and now you've got to bring them back. So I don't know. That's just me personally. Sometimes I would rather just kind of do a one and done. And if I have to be more aggressive once I've allowed it to demarcate a little bit, I don't know. Did he come back because he was having pain? Or, I mean, because that does seem a little abrupt.
They had close follow-up already planned with the patient. So they happened to have that scheduled for the day after discharge. And he was having this new blistering and a lot of pain.
Yeah, I would just say, distal partial fifth ray amps, they tend to be, one of the, I guess, better amputations to have, coverage wise, it can closure wise, easy, not that bad to close. Worst comes to worst, just put a wound vac on it. And generally, I feel I have pretty good luck with them just, healing up sooner or later. But a lot better than having that be in the middle of the foot and then having to have a lobster foot. A lot better than having to lose the big toe. If you can keep the styloid process, that'll make it so the foot can stay upright as opposed to swinging inside. But yeah, partial fifth ray amp, usually pretty good procedure choice. And I usually have a very quick trigger just to do it, just because I know generally they can get semi-normal, not normal, but relatively back to normal foot.
I would say that his flow was a little dodgy.
Yeah, and to be honest with you, I mean, the antibiotics, the blood's not getting there, the antibiotics aren't getting there really, so antibiotics wouldn't have done anything.
Yeah, I kind of agree with Jake on this one too.
So I mean, so it's a matter of do the surgery, do the wound vac if they have bad blood flow, because at least that way it's not closing over anything. And then if they are, if you guys can get some more blood there, that's great. If not, then he's just going to get more amputation until the blood thing's situated. But it seems like he had a really good, result, and that's a good one.
I think he got lucky. I think the MSSA also had something to do with it. I don't know if Dr. Noriel wants to comment on that. His diabetes was well controlled as well compared to the next two cases I'm going to present. But yes, Dr. Noriel, when you see MSSA, how do you feel about that compared to some of the other bugs on these feet? She was here. Did we just lose her?
Yeah, I think as soon as you had asked her, her name fell off the screen.
All right. All right, I'll text her, but we'll see.
She's joining
like
back
I mentioned.
on now.
Oh, she's getting back on. Okay. All right. Okay, well, we'll have more.
Hi, Samantha, I just got disconnected as I was trying to unmute myself to talk. I'm so sorry. I'm back now. for MS, this is a totally expected bug, as you all know, for this kind of osteo. I'm just curious as to the choice of moxifloxacin, but I think at that point, I don't think we had any cultures. The cultures probably came back, post-op. And one of the reasons we prefer early surgery is so that we can do culture-directed treatment, because the side effects of the regime that was chosen initially and the tolerability can be very difficult. And once we know if it's MSSE, even if you know it from a bone biopsy, we can actually target the treatment with a beta-lactam, which is definitely preferable over a fluoroquinolone for these infections. So it seems like it was a monomicrobial growth with MSSA, which fits.
Yeah, he presented with he got a wound swab that was also MSSA at the original ED visit, and was started on Augmentin for that, and then got admitted and all that business.
Yeah.
So I was actually surprised that bone culture also was MSSA, because usually it's a lot of other stuff, but
yeah, normally they can be they're very polymicrobial, and I think that's why I understand why initially there was a broad. Here we kind of have a policy in IED to narrow antibiotics very quickly. So let's say the wound culture also grew MSSA, we would have typically just narrowed the antibiotic to something like Keflex or Cefadroxil, which are easier to tolerate by patients and can be on long-term treatment compared to something like Moxie or Linezolid that causes a lot of side effect.
yeah. So I don't know. I'm not sure. Dr. Hurst or Dr. Hughes, I don't think this was yours. I think this was Dr. Michael's patient, because I was going to ask about wound care, but I can't remember. Maybe it was you that did this one?
No, this wasn't us.
Okay. But they were pretty excited about how it was looking. We were a little surprised because the patient themselves had kind of poor hygiene, and I really didn't think that he was going to heal, so I was happy. All right, here is one that I know that Dr. Michaels and Dr. Hurst's teams both know. And we finally have follow-up on this one. So this is a 34-year-old male with poorly controlled type 1 diabetes, neuropathy, and history of tobacco use. Spoiler alert, still using tobacco. He presented in September with a 2-month history of right ankle wounds to my clinic. He was referred by our podiatry colleagues who it's a pretty ugly wound, and they weren't getting a great pulse. He had been seen in the ER with feverish chills, erythema that improved with antibiotics. ABIs were erroneously elevated, but the toe pressure on the right was 15, which is anything under 50 is bad for wound healing. Was noted to have mild erythema on the wound on the right lateral malleolus and overlying a scar and liquefactive necrosis. I staged him to a stage 4 with a 2, 3, and 1. You'll see the wound here. So we have gangrenous changes, but it's not like in a major area based on wound criteria. Foot infection criteria, again, he was getting antibiotics. He had some surrounding redness. I think it was would have been a 1 on that. And then ischemia, they'll put him up at a 3. So he had significant potential benefit for revascularization. So this is the wound. It was smelly, and he did not tolerate any bedside debridement. I was sure when I saw him he was not making it through Labor Day without ending up in the hospital. But he stuck it out, and so I got him to him the next week. And a young patient, just kind of this very like smooth stenoses at the below-knee popliteal, and then above at the AT. And the rest of the foot was quite reasonable, had really nice flow, and you can see it lighting up here where the wound is. So after this procedure, he was being followed. He ended up with a fibulectomy and grew from the bone, so actinomyces and staph hominis. He was a patient that was afraid of hospitals and would never stay inpatient. And so they were just desperate, and they gave him the dalbavancin, which is these long-acting IV antibiotics. He got it ×2. That's a typo. I'm sorry. And initially was discharged on Levaquin, Flagyl, and Doxy. And he had too much GI upset, so only ended up on Doxy, and they gave him a 6-month course. His CRP went from 73.5 to 1.1. I could not find any hemoglobin A1Cs after 2019 because the patient's mainly seen at Davis for his other healthcare and it's not in our system. I've seen like as high as 14 in our system, but I was curious how that was. Took him a while to heal. This is our ABIs after we fixed his toe pressures. So you can see that's looking nice there. This is January, so still some tendon exposed. And then I'm calling it healed. It's kind of heaped on. I know Dr. Diamond has comments on that. But they did a lot of debridement, used wound vac, used Apligraph, multiple applications, collagen dressings. Patient stayed on doxycycline, and actually ended up more with edema problems from the wound and was getting Una boots at one point. His main challenges are continuing to smoke and his blood sugar control, but it looked covered. So I think we call it healed at this point, but I think it's high risk for recurring and they're following him closely. Anyone remember this patient or want to comment?
Sorry. When they did the surgery, was the incision closed primarily or was it just left open?
No, it was open with the wound vac.
Okay.
Yeah. I did not realize like how deep. I knew it was deep, but yeah, when I saw fibulectomy, I was like, oh, I really was concerned the patient was not going to keep his leg, and we will see how they do. And he continues to smoke, and his sugars are always crazy, like 600 plus when we see him. So we'll see how this patient does.
Just
yeah.
Like Samantha, for actinomyces, it is known to cause it's known to cause sinus formation, like sinus tract formation. It tends to traverse planes, like you can get cervicofacial. So if the wound doesn't heal, one of the things I might be worried about, like that's why he's still on doxy, because usually sometimes it takes months of treatment to get actinomyces actually cleared up. And they tend to form sinus tracts though. So there is a possibility if it doesn't heal that he might form a sinus tract from the skin to the bone.
Awesome. That's really helpful to know. Yeah, I figured that's why he was on this long course of doxy. I mean, they took the bone out. I think they had clear margins. So hopefully that's going to be okay for him in the meantime, but it's something that's important to know. And probably, I guess that, you would probably MRI him probably a little bit more actively if you're worried because of if you can't probe through it and you're worried about a sinus. I don't know, just thought.
No,
Would you have them on longer suppression or?
Usually for actinomyces, previous ID teaching was that they need to be at least in 6 months of treatment. Okay. Now, the newer teaching is that if you have relatively good source control and if all the infected bone is out, you could shorten the duration. But if you're like worried that this patient also has ongoing risk factors like blood sugar control, smoking, that could impair the wound healing, in those cases, I would probably keep the patient on treatment until the wound is completely healed, because even if there's a little bit of, microscopic actino left in the residual bone, it could grow and then form these sinus tracts. It's curious that he had actinomyces out of all the other bacteria grow in the wound. I don't know if this, patient's exposed a lot to soil or like, but it is a curious bug to have grown.
It's certainly possible out in the population. So that's, yeah, he had multiple debridements for that, and then they got that bone culture when they did the fibulectomy. All right, so next up. So this one is an ED patient that presented, a 55-year-old, again, diabetic patient with really poorly controlled diabetes, A1Cs from like 13 when he presented. So he was being treated at an outside wound care center across the street with this, just gangrenous black toe apparently, that overnight got much worse, came in febrile with white count, elevated CRP, very, very tender. This was recognized, of course, quickly as being a necrotizing soft tissue infection that had to go emergently to the operating room. And so taken to the OR, and this is the depth of what had to happen to try to get that infection cleared. And so underwent aggressive debridement. And pretty quickly after, and again, necrotizing soft tissue infection, you get out what you can, and then you expect that you're going to go back to get some more of that necrotic tissue. So the issue here is that heel is obviously very concerning, and then the amount of foot that had to be taken. So he was being treated with antibiotics and fluid hydration for his medical issues. His ABIs were normal. And so again, kind of went back for serial debridements, and this is kind of the stuff that we were getting. His cultures grew the following: so Echolalia, Morgani, vulgaris, anaerobes, and VRE. His stuff started to look better. He was discharged on Dapto and meropenem, and then again changed to moxifloxacin as an outpatient. Came back a couple weeks later with delayed wound healing. At that point, we discussed, we got another set of ABIs. We reviewed with the patient that, his toe pressures, like he has a reasonable waveform. He's over 50. So his actual potential benefit for revascularization was moderate at best. But, based on that, we just discussed it and felt that it was reasonable to try to see if we could improve anything. So here it's not super exciting. There's some PT origin and TP trunk disease, and then PT disease that was ballooned. And that was really all that there was to fix there. He was then debrided and got a TheraSkin. So we gave it about 3-4 days to try to, improve the flow. And then he was discharged with that on wound vac. The actual deeper OR cultures from that grew a mixed gram-positive Corynebacterium, Staph epi, coagulostaph, VRE, and Candida. And he was discharged on cefepime, metronidazole, and daptomycin. So he's progressing pretty well at this point. Now we're 2 months later. This is his office visit on April 16th. He had an aplograft put on at that visit, granulating, great. And then he goes a little nutty a couple days later, gets very encephalopathic, and rips off the wound vac, is walking around the house with no dressing on it. And this is just a couple days later. It comes altered with septicemia, and his CRP now has jumped up. And this is a different podiatrist that was on call that day and is kind of probing and seeing this stuff's kind of going deeper, and they're very worried, and he's very encephalopathic, and they're not sure what to do with the patient. And I wasn't there either. So my partners saw the patient, and because of the patient remained altered, they weren't sure if it was due to the wound or not, but the amount of foot that was involved at that point, they made a decision to perform a guillotine amp, and he got better. Our ID colleagues felt that his encephalopathy was actually cefepime induced, but he ended up with a BKA, and that's healing okay. And so that was his story. So his hemoglobin A1C is down to 10, so that's better. But this would be, a case where we were not successful, and would love to get some comments from the audience here.
So I was involved with that, as you know, Sam. So after, I think right before I did the TheraScan, I started talking to him about, Larry, there's a chance you're probably going to lose this. It could potentially go bad if we can get some blood flow. And he bled pretty nicely during that case. So I was semi-optimistic. And then we had the wound vac, an apigraph application. And then, like you said, he kind of went, down from there. At that point, like before the TheraScan, I talked to him about the DKA. He's like, let's try to save it one more time. And so that's what we did. Hindsight, should we have just said, let's do the DKA? I don't know.
Yeah, and then I was the on-call podiatrist after, yeah, that's my finger.
Mhm.
And the little pickup actually was able to basically go all the way to the other side of the foot. And if I recall correctly, the plain films just showed destructive throughout the entire Lisfranc frank ligament going lateral to medial. So even though, you know, the infection didn't cause him to go a little loopy, I think salvage was a real challenge with that much osteo in the foot. But
Yeah.
that's my recollection. I don't know. That's a couple months ago.
And again, I think it's important to note that a lot of these patients we save what we can, but especially when you look at kind of the patterns. So the ones that were saved were the ones that were being seen by a podiatrist or had been already referred, and they were trying to do stuff ahead of time. I guess this guy was getting wound care. But then his main presentation to us was not through the clinic, but through the ER. And his sugars and the other patients though were also, but this patient's a little bit older, and I think just the amount of foot that was involved was definitely part of the problem. So those are the cases. Rusty, you look like you want to say something.
Yeah, I was just saying, if I recall, I think he was being treated across the street for the heel wound.
Oh,
Yeah, initially, and then the toe and everything just kind of flared up, and he felt like it was from the heel wound.
oh, interesting. Okay.
Side note.
All right. Well, I mean, they can turn quickly. So these are ones that we have presented before, and I wanted to give everyone kind of the follow-ups on these patients. So before we proceed, I do want to call on our primary care participants just about, you know, the kind of wounds that you're seeing in your clinics and at what stage you get these patients. I could start with Dr. Brubaker.
Yeah, I guess we see a lot of the folks in the at risk or pre, I guess a lot seems unstageable or just kind of eschar on top. You know, I think some that we've called category 4s and tried to try to get seen promptly. Our little lady who loses a toe every quarter, being the most acute recent example in mind. Seeing a acutely infected toe that we had to get, like a 24-hour around kind of plan for, but we're not seeing them like that. I recall seeing them in residency in Ruby, and the stage of things that we're seeing in today's presentation, but I haven't seen any this hot in a while. Is that fair to say?
What about, well, I think someone like this, the first one. So even like someone like this, you think? You don't get them like that, you get them earlier, but then how do you decide, like, how can you tell which ones are going to be, oof, that needs to be seen, or this is going to be someone that down the line I know they're going to have a problem and get them, do I need to get them to podiatry early? Do you get any sense of that?
Yeah, kind of thinking off the top of my head, as far as probably the three main streets that we go down are either the vast majority, where the battle is fought just to like get the shoes off, control the diabetes, let us look, just let us look and document, and the like, oh, look, your feet are important, we're gonna engage you with podiatric care and get the shoes and get you used to us looking often. So that's the main, right? That's the main channel, the main slice. And then it really is. I think it's been our belief all along that a lot of the people with the worst lesions aren't the ones coming in for primary care. To a certain degree, we do get the, active ulcers from time to time, and then a really, acutely infected toe or foot from time to time. But so I group them either as like, hey, this becomes part of your chronic care, or immediate care, or podiatry within the week, are the sort of three buckets that I try to channel them into.
Kristen or Jennifer, Kayla, do you have anything to add?
I haven't seen anything quite like this. I mean, I can think of one patient that will come in every like 6 or 8 months randomly, and it's like the second case that you presented, like with an ankle wound. It's infected and tender, and I'm pretty sure we had referred that patient to you.
That was a venous one, is that right?
This was like a young guy. I think he was in his 30s or something.
I saw him, but I could tell he was never going to see me again.
Right, yeah. But nothing, I mean, I have one other patient that's already had amputated toes. So, just paying really close attention to that, but nothing like this, like gangrene or anything like that. So.
Right. I was going to ask Dr. Norriel on this one. So the patient grew candida a couple times, albicans. And what is that something you don't treat? I don't think there was ever any antibiotics given to address that. Was that a missed opportunity? Or, I mean, honestly, with the amount of foot that was involved, I don't think that was going to be salvaged. But
yeah, so we face this all the time. So every bug that you're seeing right now is a skin bug, except for the VRE. So you see Corynebacterium staph epi, coag-negative staph candida. They're all skin pathogens. VRE is something that was probably colonized by stool contamination or soil contamination in the wound. Okay, so that's not a normal skin bug. And we often in ID get stuck with these polymicrobial cultures, especially if they're just from the wound. Sometimes they even grow from the bone. So what I lay weight on more is if it's literally from the bone, and if the bone fungal culture is growing candida. If the bone fungal culture is positive and I'm already treating the rest of it and our aim is wound salvage, then yes, I would place patients on antifungal treatment to try to give them the best optimization. So remember, fungal osteomyelitis treatment is usually, true fungal osteomyelitis, the treatment is usually 12 months. So it doesn't get better in 6 months. And typically that's why surgery is the mainstay for management. It's very difficult to differentiate sometimes whether this is just candida being picked up as you're cleaning the wound and taking the biopsy because it's a normal skin pathogen, or if it's candida that's deep-seated into the bone and causing inflammation. Sometimes the only way for us to recognize that is if we ask the pathologist to stain for bacteria and fungal elements. And if the pathologist says that there's active osteomyelitis and I can see active fungal elements, it clinches our diagnosis that the candida is actually causing inflammation in the bone and it's just not a bystander over there. Does that make a difference?
Yeah, that's very helpful.
Have you seen an uptick in the resistant strains of Candida that are now being found in acute care facilities? And now we've got a couple cases here at Ruby.
So once you see Candida in the bone, I typically ask my micro department to not only identify the species, but also give me the susceptibility pattern. Normally, albicans would be universally fluconazole susceptible. There's very, very rare resistance of albicans, but there are some Candida that are inherently resistant to fluconazole. Cruzii, for example. But Candida glabrata, which is more commonly seen and which is more commonly encountered, again, can have high dose fluconazole susceptibility pattern. So if I was going to truly treat a Candida osteomyelitis, I would want to know if it's a fluconazole susceptible strain, because apart from azoles, our only option would be IV caspofungin, and it's unrealistic to think somebody's going to stay on IV caspofungin or like anadolafungin or some of these micafungin treatments for echinocandin treatment for a year. In those cases, if you're dealing with a resistant Candida osteomyelitis, short of amputation and surgery, the chances of cure are minimal.
Yeah, we had like the new one that we had to report to the Department of Public Health, and like all the
Auris.
patients had to be.
Yeah,
Yeah.
Candida auris. Yeah.
Yeah.
Started at
I
Yale
had
actually
one
when I was
patient.
a resident. So-
Awesome. All right. Well,